We'll keep questions for the end. Our next speaker is Dr. Drushti Raichura. She is an upcoming vitreoretinal surgeon, practices in Mumbai. So she is going to talk about spots in the field of vision. So what could they be?
Good afternoon, one and all. Thank you, Dr. Paritosh, sir, for giving me this opportunity. So my topic is, I see spots in my visual fields and what could they be? So a vitreous floater, or known as myodespsia in Greek or muscae volitantis in Latin, is nothing but a clump of microcollagen which condenses and casts a shadow on the retina, which the patient sees in the visual field. It can occur due to vitreous syneresis or liquefaction and contraction with age. Also, it could occur due to trauma and injury. So the patient will present with either floaters or bubbles or cobwebs, dark spots, bugs, or thread-likes floating in the visual field, which move with the movement of the eye. They are more seen in dim illumination, more in the temporal visual field. Now, if we ask on history, the floaters or scotomas due to the vitreous floaters will move even after the cessation of eye movement, whereas a scotoma or a defect which is seen due to a corneal or macular or lens pathology will remain constant. So this is what the patient will see, and if you see in this diagram very nicely, it has been depicted how these floaters cast a shadow on the retina which the patient sees in the visual field. So primary floaters are due to endogenous structures of the vitreous, that is the collagen. So patient will classically complain of glass noodle or spider web-like appearance. And secondary floaters are due to exogenous structures in the vitreous like amyloid, blood, implants, parasites, or foreign bodies. So primary vitreous floaters, the most common cause is posterior vitreous detachment, where the patient may complain of seeing the Weiss's ring or ring-like floater. Or there could be vitreoretinal disorders like Stickler syndrome or Wagner disease. Secondary vitreous floaters can occur due to retinal or pre-retinal or vitreous hemorrhages. There could be breaks, tears, or operculum in the retina associated with or without retinal detachment. Sometimes, very rarely, due to asteroid hyalosis, which is significantly dense enough to cause floaters, or intraocular injections or remnants post-VR surgery. So when a patient presents to you, how should you go about? So the first most important thing is a very detailed history taking, which we'll cover in the subsequent slides, followed by slit lamp biomicroscopy with our 60 or 90D lens, a peripheral fundus examination with scleral depression in both the eyes, documentation either in the form of a mechanical drawing or imaging if available, and last but not the least, counseling the patient. So in the history, you have to elicit whether it's an acute or a chronic problem. What is the number and density of the floaters, if there is any increase since the time it started. Also, you should find out about metabolic disorders if the patient is suffering from any diabetes which could lead to vitreous hemorrhage or hypertension. Any previous history of retinal diseases like retinal detachment in the other eye, then you know that you should look more keenly for a break in this eye which he is complaining of. Vascular occlusions and any ocular surgery like cataract or VR surgery. Cataract surgery, especially if there's been an eventful cataract surgery where there could be some remnant cortical or epinuclear fragments in the anterior segment or posterior segment. So on slit lamp biomicroscopy, through a 60D lens, these images have been taken. And here in the first image, you can see in the superior periphery, the floater which we can see. Here it is just next to the disc. I think because of the contrast, we cannot see the disc. And here you can see a kind of Weiss's ring PVD. This is a video which we've taken on the slit lamp with the 60D. So if you look, you have to basically increase the brightness so that there is more light thrown on the retina, so that the light which comes on the vitreous thrown from there will show you the ring very nicely here. So this is through slit lamp biomicroscopy. This is how you should examine the vitreous. This is another video which is taken on the slit lamp. So you should basically, like I said, increase the light on the retina. Now you can, once you focus on the retina, you bring the joystick a little forward, focus anteriorly, and very beautifully you can see the vitreous movement. I mean, here there is a liquefaction of the vitreous. And so very nicely you can elicit that just on your slit lamp examination. I think due to lack of contrast, you cannot see it very well. Okay. Okay. Sorry, I am not able to see it probably. So the most common cause being posterior vitreous detachment, which is an age-related common process where patient will complain with sudden onset of floaters. There is separation of the posterior vitreous cortex from the ILM of the retina, progressively extending up to the vitreous base. So it is basically liquefaction along with vitreoretinal dehiscence, which allows the liquid vitreous to enter the pre-retinal space. These patients need to be kept under a very close observation, and we have to explain the importance of that to them. So on wide field imaging, this is what the posterior vitreous detachment would look like. The next cause being vitreous hemorrhage, which can occur due to PVD with traction on the retinal vessels, ischemic conditions leading to neovascularization like diabetes, retinal tears which involve the retinal vessels and hence lead to the hemorrhage, trauma, neoplasms, rare anomalies like X-linked schisis Stickler syndrome, and retinal detachment with pigment release. So these are pictures of vitreous hemorrhage where you can see that the periphery of the retina can be seen and the hemorrhage is in the center. These are cortical spokes, but you just can't go with the image. Clinical correlation with the lens status is also important, so that needs to be ascertained. These are streak intragel hemorrhages, so these patients also can present with floaters. Any avulsed retinal tissue like a break or a tear or an operculum these patients can also present with floaters, and hence indirect examination of both the eyes with scleral depression is of utmost importance. Asteroid hyalosis very rarely will present with floaters, but if it's dense enough and if the number is too much, then the patient may rarely present with floaters. Asteroid hyalosis is nothing but calcium pyrophosphate crystals, and as such they cause minimal disturbance. Intraocular injections in the form of anti-VEGFs or dexamethasone implants or IVTA crystals could themselves present with floaters, but eventually they resorb with time. Even the small amount of air which sometimes goes into the vitreous cavity can present as a floater. Post-VR surgery, any remnant PFCL or silicone oil bubbles which have been left behind. So this is a picture of a retinal tear with a detachment, which I think subsequently Ashish sir is going to cover. This is an operculum. This is asteroid hyalosis. Here it is significant enough, and on slit lamp examination also you can appreciate the same. Here we've taken a video on slit lamp to show how that movement is seen. So during your slit lamp examination, you should have an eye out for it. This is a shadow of the Oziodex implant on the retina, and this patient we've been able to capture the implant. So these patients also complain of seeing a cigar-like floater in the vitreous field, in the visual field. This is gas after VR surgery. This is in the form of a single bubble, and here there are multiple bubbles. Here, this patient was complaining of a floater, which on clinical examination we were not able to find the reason for. But when we took the wide field imaging, we saw that there was one remnant silicone oil bubble which had been missed on examination. But luckily on the photography on imaging we could pick it up, and then we knew that that was the cause of the floater. So patient counseling is very important regarding frequent follow-ups, especially when you know there is a PVD. You should see them every week or so for the first month, and then you can increase the duration gradually, so that if there are any breaks or anything which develop, you catch them in time and you prevent the patient from going into an RD and undergoing surgery subsequently. You have to explain to the patient that they have to inform SOS if there is an increase in the number of floaters, or they see flashes, or there is a drop in vision. And if you don't find any other cause, you should also get the necessary blood workup done to find out for diabetes and all, to find out for the other causes of vitreous hemorrhage as well. I thank you all for your patient hearing.
Thank you, Drushti, for a wonderful presentation. All my patients, all the retinal patients, we commonly counsel them to remember certain warning symptoms. So apart from a sudden drop in vision or waviness, that's metamorphopsia, we tell them about to watch out for a sudden onset of new floaters, or a sudden shower or fountain of red, brown or black dots lasting 15-30 seconds, and then again vision becomes clear, or flashes of light like lightning in the evening darkness or night on moving the head or the eyes. So if any of these are seen, then these are warning symptoms of a serious retinal pathology, and we tell them to report immediately.